functional urology. Well, before we begin, please allow me to greet our distinguished speakers. Good morning, Professor De Ridder.
Good morning.
And good afternoon, Dr. Harrina. Thank you for being with us.
Good afternoon.
I think Professor Oh is not here yet, but he will be soon. First of all, I would like to inform all of you that the format of this webinar will be 20-minute presentation, followed by 5 to 10 minutes discussion with each speaker. Should you have any question or comments, please do not hesitate to type it in the chat box, and I will bring the question or comment later in the discussion. Okay, without further ado, let's begin with our webinar. The first presentation is Professor De Ridder with the topic bladder pain syndrome from bench to bedside. And for your information, Professor De Ridder is a professor and chairman of the Department of Urology in KU Leuven, Belgium. He is also former chairman of European Society for Neuro Urology, part of European Association of Urology. Professor De Ridder has more than 200 publications, which has been cited more than 6,000 times, and it's an AIDS index of 38. Professor De Ridder, the time is yours.
First of all, thank you for the very kind invitation. It's nice to see some of you back, Jodi, Dodi, Lukman, and Anugrah. Anugrah is, of course, at this moment here with us in Leuven as a PhD student. And it's heartwarming to see that the collaboration that started many years ago with Lukman is now fulfilling itself and is continuing and working towards a nice collaboration between Surabaya and our own university. I have been asked this morning to talk about painful bladder syndrome. I could actually make this talk very short and tell you that there is not much new under the sun since the 80s, but of course this would be too short as a presentation. But I will run through this entire field of expertise in a few slides. Painful bladder syndrome and interstitial cystitis is actually a minefield of definitions. Every organization has its own definitions. Definitions can be based on patient perception, can be based on outcome of questionnaires, on cystoscopic findings, histology, sometimes used based on urological terms or terminology, and often and more often now based on pain clinic terminology. So it becomes very difficult for a young urologist or for a trainee to find his way in this minefield of definitions. Actually, the original definition of 2002 by the International Continence Society is still the one that holds up until now. They talk about two syndromes. One is painful bladder syndrome, which is the umbrella term. And this is suprapubic pain related to bladder filling, so increasing pain during the filling of the bladder, with frequency and urgency in absence of other relevant pathology, for example, a urinary tract infection. Interstitial cystitis is a subgroup of painful bladder syndrome, with the only difference that in interstitial cystitis you will also see cystoscopic or histological findings in an absence of infection. So it's important to know that painful bladder syndrome is an umbrella term. Interstitial cystitis is the group in patients where we see cystoscopic abnormalities. And I will come immediately to that. Even within this group of interstitial cystitis, there are two subgroups. In 2005, the ESSIC, which is the European Society for the Study of Painful Bladder Syndrome, actually repeated this definition, but refined it with an increased daytime frequency of more than 8 times and a nocturia of more than 1 time with cystoscopic findings and or histological features. So the important thing and an important message here is to know that you cannot prove interstitial cystitis by histology. You can only associate some histological findings like infiltrations by polynuclears, for example, that there is something going on in the bladder wall, but this is not pathognomonic, it's not proving that it's interstitial cystitis. It's only the cystoscopic finding, the cystoscopic image that will prove interstitial cystitis. Just to highlight this difference in approach and difference in terminology, I just picked out two guidelines, one from the AUA and one from the East Asian guidelines. And you see that the Americans that talk about interstitial cystitis bladder pain syndrome, while East Asian talks about hypersensitive bladder symptoms and a hypersensitive bladder. So this is a publication from Arun Sahai, a senior author from London, who actually looked at all the existing guidelines, and I think he compared 8 or 9 of them, and it's actually a total mess. Nobody knows how to tackle this very difficult and annoying problem, and certainly there needs to be more interaction between the scientific societies to come to a clearer definition and a clearer outline of what this problem actually is. As I said, the chronic pelvic pain syndrome, bladder pain syndrome, interstitial cystitis. Well, in this interstitial cystitis group, again, there are two groups. There is one group where you hardly see any bleeding in the bladder wall after distension. You see some petechiae or some glammerulations, and I will show that in a few minutes. Or you can see ulcerative lesions. It's called ulcerative lesions based on the fact that Mr. Hunner, who was the first to describe this, had a cystoscope dating back into the 60s with very poor vision and light. So he thought he was seeing an ulcer, but now with the new cystoscopes and the new lighting systems, we know that it's actually not an ulcer, it's actually a crack in the lining of the bladder, and I will come back to that in a few minutes. So in the interstitial cystitis group, you have two groups, the one with petechia and glammerulations, and the one with ulcerative lesions. That is now seen as a separate entity because it will respond differently to treatment. What about the underlying mechanisms? Well, we know that in painful bladder syndrome and in interstitial cystitis, there is something wrong from the urothelium and the layer that covers the urothelium, the glycosamine layer, glycan layer. From that point, intraluminal, throughout the bladder wall, the nervous system, probably the muscular system, and then the central nervous system up to the brain, we can find abnormalities in every compartment of the micturition cycle. So this means that it becomes terribly complex to find actually the real cause of this disease. Probably there is a common denominator that we do not know yet between interstitial cystitis and some of the gastroenterological entities like Crohn's disease or irritable bowel syndrome or inflammatory bowel syndrome and interstitial cystitis, but we cannot identify this common denominator at this moment. But the components of the symptom actually go from bladder symptoms caused by local irritation of the bladder wall to the response by the nervous system and the response by the brain and also the emotional system in the brain. And this makes that this is a group of patients who are sometimes very difficult to talk to. We know that there are changes in the dynamic signaling between the bladder lumen, the urothelium, and the efferent nerves. We know that there is an adaptation from the hypothalamic, pituitary, and adrenal axis, stress-induced situations. We also know that many of these people will show emotional affective symptoms due to a different sensory processing in the limbic system. And Anugrah is now starting a project here in Leuven to start exploring this. We know that there is peripheral hyperexcitability due to bacterial infection, a viral infection, inflammation, and changes in urothelial permeability. And we know that the central nervous system will adapt to these problems. And we also know that there is a high risk of depression and anxiety in this population. And there is an association with other visceral pain disorders. There's a large overlap with irritable bowel syndrome and people who have actually a bladder pain syndrome because of the pelvic organ crosstalk. So it's a very complex system that we hardly understand at this moment, and we will need time and money and interest from companies to actually explore this. Just a small illustration. This is a publication from now nearly 10 years ago, but just look at the drawings here. This is electron microscopy of the bladder wall. These are the interstitial cells under the urothelium, these lines that you see here with spindle-like cells. This is how they change in neurogenic bladder. They lose their connectivity and there is a large deposit of intracellular matrix. And here in interstitial cystitis, you see that these cells, which is actually a kind of control center and the liaison center from urothelium to the nervous system and the underlying detrusor, changes completely. These cells lose their connectivity, lose their function, and there's a lot intracellular matrix that is being deposited. So we know that there are vast changes in this urothelium, but we do not know at this moment what is driving these changes. Important to know is that the key symptom in these patients is pain, urgency, frequency, and nocturia, but pain is the most important one. And you have to exclude other conditions. So the mistake that I often see here in our population is that people are being kept on the line, being treated as recurrent urinary tract infections, but recurrent urinary tract infections, they have urinary infection signs. So they will have urgency and frequency, of course, they will have some algiuria, but as soon as you give an antibiotic, the pain will go away. In these patients, the pain will often persist or recur very often. So in patients who have recurrent urinary tract infections, but also complain of pain, please think about interstitial cystitis, because this can save months or years in a correct approach for these patients. Exclusion of other conditions like infection, bladder stone can be done quite easily by medical history, physical examination, a dipstick, a PSA in men if appropriate, uroflow, and a cystoscopy and biopsy. If you do these things, which you can all do in the office, then you can actually exclude most of the underlying conditions. The only thing maybe that you should think of is a urethral diverticulum. This is not a prostate of a man. This is a urethral diverticulum in a woman. So this is a diagnosis that is sometimes overlooked and that can mimic the symptoms of a painful bladder syndrome. So a careful clinical examination or a good vaginal ultrasound or eventually a CT or an MRI scan will actually make this clear. As I said, it's often associated with inflammatory bowel disease, Crohn's colitis, with lupus, with fibromyalgia and chronic fatigue syndrome, with irritable bowel syndrome up to 30 times more, and also with panic disorders. Again, this is for the gastroenterologist, a group of patients who are very difficult to manage and where the gastroenterologists probably are a little bit further in the research than we are. They make progress in the treatment of irritable bowel and inflammatory bowel disease, while we are still lagging behind on a good treatment for interstitial cystitis. I talked about cystoscopy. The key intervention in the diagnosis is actually a hydrodistension procedure. You cannot diagnose interstitial cystitis by doing a cystoscopy in an outpatient clinic without anesthesia. If it's a real interstitial cystitis, it's simply too painful. So you have to put the patient under anesthesia, be it spinal or general. You fill the bladder up to 80 centimeters of water pressure. So you put your water column 80 centimeters, 60 to 80 centimeters above the belly of the patient. You keep it for 1 minute at that pressure. You note, of course, the capacity, and you drain the bladder, and then you fill it again. At that moment, usually the bladder starts to seep with blood, and it's very difficult to find your way in the bladder. The trick there is actually to push your cystoscope as close to the bladder wall as possible and then work around from that point. And then you will see that after a few minutes, the bladder will clear up and your vision will improve. This is what I meant with the different classes. In some patients, you will only see little point bleedings, petechiae, distributed over the entire bladder or a part of the bladder. And in some forms, some patients, this will be confluent. These petechiae will form a kind of blob, and that even can be interconnected, as you see here. This is described as a grade 1, which means petechiae in more than 2 quadrants, or as a grade 2, where you have larger submucosal bleedings. This is a separate group. These two are grouped together. This is a separate group, which is completely different from what I'm showing here. And this is what we call a Hunner ulcus. So Hunner saw this as an ulcus, but we see this as linear cracks in the lining of the bladder wall in the urothelium. And from these linear cracks, you will actually see that some blood drops can actually seep down. And this is a pathognomonic finding of interstitial cystitis with Hunner ulcerative disease. Usually the bladder capacity in these patients will be much lower than in the patients I just talked to you about. often the capacity of these patients is 150 to 250 ml, while in the other ones it can go to 400 or even 600 cc's. But remember, if you see this 100 alkys, this patient group will respond differently to treatment. And so this is now accepted by more and more groups, by ESIC, for example, but also in a recent consensus meeting, which is in 2019, the publication is noted here. You have the classic interstitial cystitis with the ulcerative lesions. They have debilitating symptoms. They have a destructive inflammation. There's a fibrotic process in the bladder wall, which will lead to small bladder capacity. And you have these typical cystoscopic findings, which I just showed you. The non-Hunter disease have initially a normal cystoscopy. They can show some glomerulations of petechiae, but they will respond differently to treatment, meaning that the non-ulcerative disease will respond to medical treatment to some extent, while the classical Hunter lesion, they will actually lead at a certain time, over a certain course of time, in most cases to a cystectomy, because that will be the only possible treatment for these women. Recently, under the pressure of the pain societies, we now started and having the problem that we do not know what the actually underlying cause is. We try to treat the patient now in a more holistic way, meaning that we will not only look to the urinary symptoms, but also to the psychosocial symptoms, to other organs that are involved. We will eliminate infection, we will look to the neurological system, and we will use tenderness or trigger point techniques, try to alleviate the symptoms of the patient. This is a holistic approach, simply because of the fact that we cannot offer a causal remedy for these patients. So we have to support them in more than just a urological way of doing. Treatment-wise, we have more than 183 different treatments that have been described in the literature. Bladder distension itself will have 50% temporary improvement, and there are a few FDA-approved treatments like oral pentosan polysulfate, I don't know if you have it in Indonesia, or intravesical DMSO, which is now a little bit fading out. But I will go through the medical treatments. Common analgesics like paracetamol or aspirin, visceral pain does not respond to these analgesics. So there is no point in giving these patients high doses of paracetamol because they will not respond. Opioids will respond in selected patients, but then of course you will make the patient opioid dependent, which is a problem by itself. Steroids have been tried. You have variable results, but of course unacceptable side effects. In older publication, antihistaminics were recommended, and especially hydroxyzine, Atarax. But actually, this drug is now no longer used because it has serious side effects of sedation and weakness. Probably by giving these patients Atarax, you just make them numb and you do not actually treat them, but they are more easy to treat or to deal with because the sedation of by the Atarax. However, there is a small group of patients who will tell you that they are, for example, not tolerating tomatoes. It's a typical acid vegetable, that they are not tolerating acidic food. These might be helped by this Atarax, probably because some form of immunological or allergical constitution. The key to the treatment is at this moment still the tricyclic antidepressants like amitriptyline or Redomex. And the newer ones like duloxetine and pregabalin or gabapentin can be used as well. These drugs have a complex mechanism of action. They are not only anxiolytic, but they also increase the pain threshold and they decrease neurogenic inflammation. So they work on different components of the disease we are dealing with or the syndrome we are dealing with. So if you can convince your patient to, and if the patient tolerates amitriptyline or duloxetine, this is certainly the first step in the treatment. It will take several weeks before they have 3 to 4 to 6 weeks before they have a clear advantage of this, but you have to convince them to use this as a basic medication. Other medication has been tried, prostaglandins, azathioprine, methotrexate. Some has effect on pain, less on urgency frequency, but anticholinergics can also be added to this amitriptyline. Amitriptyline will work on the pain, while your anticholinergics or Betmiga will work on the urinary frequency. So you can tackle the two components, the pain components and the urgency frequency components, in a separate way by giving two separate drugs. What about intravesical treatments? There again, anything is possible. You can use the pentosan polysulfate, hyaluronic acid, heparin, DMSO, which is a chemical solvent actually, or Botox. Hyaluronic acid, heparin, they have a very small response and a very short response. They will only respond for 2 to 3 weeks. And so these patients need to have this treatment repeated at a very high pace, which is logistically challenging and which is financially challenging, because in many systems, these drugs are not reimbursed. DMSO is very inexpensive, but has serious side effects. It's a burning sensation for the patient. The patient will absorb the DMSO through the bladder wall. The skin will turn in a kind of green, so they look like the Hulk a little bit. And they have a very annoying garlic odor for 2 to 3 days, which actually lead to the fact that the partner will not sleep with his spouse anymore because of the smell. So this has a devastating effect on the quality of life of the patient, but it can help in serious or very painful situations to alleviate the pain for a longer period of time. What DMSO does is just get rid, dissolve of many of the receptors in the bladder wall, and it will desensitize the bladder for a few weeks. Botulinum toxin is actually a drug which seems to work in especially the patients without ulcerations. So the patients with urgency frequency and some petechiae or glomerulations, they can respond up to 9 months with bladder injections. And if they also have spastic floor at the same time, you can also use levator ani injections to alleviate the pelvic floor spasticity, which often goes along with this syndrome. There's a very nice Chinese review of the intravesical treatment. They did a kind of meta-analysis. It's actually a nice paper which you should look at, because they used a very interesting methodology to compare all these drugs which you see here, oxybutynin, botulinum toxin, BCG, RTX, and PPS, to placebo. And the thickness of the line represents the quality of the data, for example. But here you can see that they conclude that botulinum toxin has the highest probability of being the best therapy for improving the global response assessment by these patients. BCG can actually be offered as well, because it improves the symptoms of urinary urgency, and PPS also improves urinary frequency and urgency. But botulinum toxin is the best of these other options. BCG, I don't know how it is in Indonesia at this moment, but we can hardly get any BCG in Europe at this moment, so we can certainly not afford to use this for this kind of patients. We actually keep it for our patients with bladder cancer. In laser treatment, and this is our standard approach, we will actually do a hyaluronic under anesthesia. And if we see these ulcerations, then we will laser the ulcerations with a holmium laser, which will turn a side like this, where you can see the linear cracks, into a cooked part of the bladder. But this will improve the pain symptoms of the patients, but also the urgency and frequency of the patients in more than 80% for a duration of at least 8 months. So this means that even patients with ulcerative disease can be kept in a good condition by repeating this laser treatment over and over again. I have patients with ulcerative disease who have undergone this treatment 10 or 12 times, but actually what we see is that the bladder capacity also remains stable in these patients. In the 20% remaining patients that do not respond to this treatment, we will see that the bladder capacity decreases gradually from 300 to 100. If you have a bladder capacity of 100 cc under anesthesia, this means that in real life, you are more going and coming from the toilet than anything else, and this is going on during the day and during the night. These patients will beg you to do a cystectomy at the end. A lot of alternative treatments have been used with variable successes. Mostly you will find 1 or 2 publications by believers, and then no follow-up publications, no comparative publications. So People can try anything for going from acupuncture, massage, TENS, sacral nerve stimulation, hyperbaric oxygen. Everything has been tried, but also all with very variable success. What about cystectomy? Cystectomy is the final resort, and there are only limited reports on the outcome of cystectomy in these patients. Initially, in the 80s and 90s, trigonum sparing cystectomies were performed. Actually, the trigonum was left in place, and then there was a large bladder augmentation done. Reported in 90 patients, 12 patients failed, and then they had to do total cystectomy anyhow with diversion, with again the resolution of the pain problem. We now also always do vaginal sparing total cystectomy. Then there can be need for intermittent catheterization if you do a replacement bladder, or we will use more and more, depending on the age of the patient, a normal Bricker diversion or ileal conduit. The best results here are in patients with classic ulcerative disease with small bladder capacity. In non-ulcer disease, it actually doesn't work. There, the pain will often persist because of underlying central nervous system adaptations. So the IAU has looked at it, and the IAU is at that moment under vast influence by the pain societies. So here you can see that if there is a pelvic pain syndrome, they will actually start to divert the patient or offer the patient treatments and consultations in all specialties that can be involved, trying to phenotype the patient. In some points, I think that this is just sending the patient around until he or she gets bored with it and stops seeing you. In some cases, it's really necessary to send the patient to a sexologist or gastroenterologist or whatever, but be careful of not just sending patients away. I think the urologist should keep the control over the patient and be very thoughtful about asking other colleagues to interfere. This is a very simple guideline, and I think it's one of the best actually. If you do hydrodistension and you see a Hunter lesion, then you can go for TUR or for laser. If it's adequate, you retreat. If it's inadequate, then you can try whatever you want. If you don't see a Hunter lesion, in this case, you start with oral agents. You can use TENS. If it's inadequate, you can use intravesical therapy. And there we have seen that Botox is probably the best, followed by BCG or DMSO or another drug. And if it's still inadequate, then the patient needs to go to the pain management units, because we as urologists can then no longer do something for the patient. In this patient, in this group where we actually don't have adequate treatment, there will be the subgroup where we will do a cystectomy. So what is the quality of the evidence? Pentosan polysulfate has strong evidence. Botulinum toxin has strong evidence. Ablative surgery only by surgeons who are experienced and know how to deal with this kind of population. Transurethral resection or coagulation or laser is also limited for patients with ulcerative disease, and botulinum toxin is certainly an option if other intravesical therapy has failed. This phenotype-oriented therapy is strongly recommended. I'm a little bit doubtful about that, but of course you have to have a multimodal approach to this patient. You have to be open to discuss the psychological impact. You have to be open to discuss the behavioral impact and the sexuological impact with your patient. You have to treat the patient as a whole, but you don't need 10 specialists to do that. And then amitriptyline is strong recommendation, and pentosan polysulfate is strong recommendation. Actually coming to a conclusion and looking forward to your questions, unfortunately in this field, not a lot of progress has been made over the last years. There are some new emerging therapies and some new emerging approaches to this, but they did not get confirmed yet in larger studies. Stem cell-based or cell-based therapies seem promising, but it's in very small publications and there are never follow-up publications. So I'm doubtful. It can be a one lucky shot, and I'm not sure that this will actually stand the test of time. But if any of you is interested in doing research on this, the American Society for Interstitial Cystitis is a very rich society. And if you have a brilliant idea, you can always submit your brilliant idea to them in the hope to get some money from them, because they sponsor even abroad, outside of the States, because of the devastating nature of this disease. Thank you for your attention. I hope that I'm within time.
Thank you, Professor De Ridder, for your presentation. Currently, we have 3 questions. The first question, can you share your experience with pentosan polysulfate, either oral or intravesical, Prof?
Yes.
In Indonesia, we have PPS, but still off-label. So yeah, we would like to know about that.
When you look at the publications of, we don't have it in Belgium, but I have patients who ordered it in Germany or Holland, and actually we have some experience with it based on the stories of these patients. If you look to the literature, actually it takes up to 6 months before patients start to feel improvement of the symptoms. I would be worried if a drug that I'm taking only shows a benefit after 6 months. I don't think this is a very good drug. So I'm not really convinced that oral PPS will actually do a lot. I think it's a good placebo, or a placebo with some extended effect. I don't know how. But also, if you look into the publications, there is evidence, but the evidence is actually quite weak. The randomized control studies that have been done, they are randomized, but they are not the best randomized control studies. They are old. Inclusion criteria, exclusion criteria of the patients were not very clear. So I'm a little bit doubtful about the real effect of this PPS. I think for intravesical treatment, however, it is better, because there it actually can restore this glycosamine glycan layer, which is protecting the underlying urothelium in some way. So this could be a better approach. But as an oral treatment, myself, I'm a little bit doubtful about that. I am using amitriptyline or gabapentin as first approach with my patients.
The next question, do the symptoms usually recur after a good response? I mean, if you, so do you use the same treatment?
You mean in the non-ulcerative disease or ulcerative disease?
In the ulcerative.
In the ulcerative. In the ulcerative, as I said, this laser treatment that we use here, we can repeat this as often as we want. The advantage of using holmium laser instead of electrical coagulation is that with holmium laser, you only penetrate for a few millimeters, or not even a few millimeters in the bladder wall. So this will create actually very little scar tissue. If you use electrical current, if you use a TRB loop, for example, then you will create a fibrotic part in the bladder. And there, if you repeat this often and often, you will actually see that the bladder capacity starts diminishing. So many years ago, we did a little comparison, and we saw that in laser treatment, the bladder capacity remains stable, while in TRB retreatment, the bladder capacity goes down. So this is the reason why we opt for laser treatment. And as I said, I have patients who have undergone this 10, 12, 13 times and can actually keep their pain under control and actually keep their bladder capacity at a reasonable level. So for the ulcerative patients, this is certainly our standard approach. The 20% to 30% that do not respond to this and that recur, there we will repeat it anyhow, but then we know that after 2 to 3 times, the capacity will be so low under anesthesia, and my cutoff is 150 to 200 cc's under anesthesia. If we reach that point, I will start talking about a cystectomy. Because the functional capacity of that patient will even be lower, will be around 100 cc's, which means that they actually have to go to the toilet every 100 cc's, meaning at least 20 times on a day if they drink normally. And this has no life anymore. So their quality of life is so bad that they actually ask for a cystectomy at that point. In the other group, the non-ulcerative disease, there we will actually try different regimes, starting with amitriptyline. If that doesn't work, we do go to duloxetine or gabapentin. And if that doesn't work, we will actually send them to the pain clinic for more advanced pain therapy. Because then we as urologists can no longer do something for these patients. These are patients with a centralized pain syndrome which we cannot control for them.
Thank you, Prof. And another question regarding hyaluronic acid, do you still use regularly in your clinical practice? Or
what? Sorry?
Hyaluronic acid, intravesical hyaluronic acid.
Yes, we still use it for the first group of patients, the non-ulcerative disease. If they fail their oral treatment, if this is not sufficient, we will offer them 6 courses of intravesical treatment. And here we use hyaluronic acid as a standard at this moment. And then we will evaluate the response after 6 treatments. We do this once a week. And then we will see if we can actually make the time between the installations longer. Then we will go to 1 a month, 1 every 3 months, and then see if we can keep the patient in a stable situation like this.
Another question, Prof. One of colleagues have a schizophrenia patient with problem control of her micturition. Does Botox can do?
Yes.
If it does, and how much is the dose you recommend for this kind of patient?
Yes, psychiatric patients, psychotic patients, or other psychiatric disorders are difficult, and you have to realize that bladder overactivity can either be induced by the medication they are taking, by the cocktail of psychopharmaca that they are taking, but it's very difficult to convince psychiatrists to change the medication. So if they have overactivity, then you can of course use Botox, and I use 100 units of Botox. But you have to do urodynamics in these patients, because some patients, psychiatric patients that are taking a cocktail of psychopharmaca, actually have a strange urodynamic finding. They will have a long filling phase, which is actually leading to a capacity of 500 or 600 cc's without any sensation. And then suddenly, when the bladder is nearly full, they have first sensation, strong desire, and then they leak, or they start leaking or start voiding. So it seems that their sensation of the bladder is reduced or pinned down by this cocktail of anticholinergics. If you will give Botox to those patients with this urodynamic finding, they probably will go into retention. So these are not really responding to Botox. There you have to talk to the psychiatrist to actually try to make the cocktail of psychopharmaca in such a way that it has less of an anticholinergic burden, that there are less drugs in it with anticholinergic side effects, because that's probably the underlying problem.
Thank you, Prof. Another question, what is the implication of grading of interstitial cystitis by cystoscopy for the treatment? Is there any difference or?
Yes, because you will make the distinction, and only you will make the distinction by doing that, is between this ulcerative and non-ulcerative group. Okay. You need to know in which group the patient is sitting, because this will guide your treatment and will define the future of the patient. So you need to do this. If you don't do this, you will actually be chasing symptoms without knowing what you will bring to the patient. So the way I talk to patients is completely different if they are non-ulcerative or if they have an ulcerative disease. The ulcerative, I know that they are going for invasive treatment, eventually cystectomy. The other ones are going for as conservative as possible.
And regarding the ulcerative patient, any difference as well between the grading and the outcome of the treatment?
No, it's very unpredictable. And ESIC, I left it out because of time. ESIC is recommending a kind of study, or at least registry, to see if there is a correlation between the histological findings and the outcome of the patient. But actually, so far, no correlation was found. So we are still looking in the mist a little bit on what the actual drivers would be for these different evolutions of the patient.
Okay. The next question, do you have any dietary or liquid intake recommendation or restriction for patients with PBS or?
Dietary, no. I will ask them if they actually felt or noticed that they are intolerant to some medications. So as I said, some patients will say that, for example, typical story here is that I do not tolerate spicy food and I do not tolerate tomatoes, for example, because it can be quite acidic. Then we will actually ask them to avoid this, which they usually do by themselves. But these patients, we will also give them some antihistaminic drug to try if this improves their outcome or not. In about 50% of them, they will say that if we give them also an antihistaminic, next to the amitriptyline and all the rest, it improves their quality of life. So, but this is trial and error.
Okay, another question. How is the actual mechanism of hydrodistension in the treatment of IC and BPH?
It's a very good question. I like the question because if the theory about a glycosamine glycan layer, the protective layer on the urothelium, and if you restore this, the patient will improve. If this would be true, then a laser treatment should not work at all because we destroy the entire layer. I think the working mechanism is that the interstitial cystitis is not present in the entire bladder. It's localized in patches or in quadrants. So this means that the bladder itself is not entirely sick, which is only zones that are inflamed at that moment. If you destroy these zones, you actually kill the underlying sensory nerves, you kill the urothelium, and you have several weeks or months before this is restored. Once it is restored, the pain problem can reoccur and you have to repeat the treatment. So I think it's just at this moment a very crude mechanical way of destroying urothelium, underlying nerves, receptors by lasering them. While you can spare the zones that are not inflamed at that moment, and then you repeat it over. So I think it's just burning away the pain. I cannot describe it in another way. We simply do not understand enough of the underlying pathophysiology to give any sensible answer to that question.
Thank you, Professor Dirk. I think because we have a very limiting time, so we will go forward to the second speaker, which is Dr. Harrina. Thank you so much, Professor Dirk.
I have to leave you, but it was very nice to meet you all, and I wish you a lot of luck with this webinar. See you all.
Thank you, Prof.
Hopefully I see you back in Indonesia sometime.
Thank you.
Okay, bye-bye.
Bye, Prof.
Bye-bye.
Our second speaker is Dr. Harrina Rahardjo. She is the staff member of Department of Urology in Indonesian University. And Dr. Harrina Rahardjo is also the chairman of the Indonesian Association of Female and Functional Urology. Dr. Harrina Rahardjo has more than 37 research and more than 28 publications in national and international journals. Dr. Harrina, the time is yours.
Thank you, Dr. Anugrah. Is my voice clear and the slides are okay?
Yes, Doc.
Okay, thank you. So thank you very much for the introduction, and for those who celebrate, happy Islamic New Year. And I will discuss together with you regarding the management of Nocturia with the highlight on the new Indonesian Guideline 2020. So the outline of this presentation is as follows. Definition of Nocturia, the prevalence, diagnosis and management, and we're going to talk a little bit about desmopressin as the drug choice for Nocturia, and then we conclude the session. For the definition of Nocturia from the International Continence Society is the number of times urine is passed during the main sleep period. And nocturnal polyuria, which is the main cause of the nocturia, is the excessive production of urine during the individual's main sleep period. So there are a lot of survey or a lot of studies done on nocturia prevalence around the world, but I'm going to share to you our survey in Indonesia done in this year in 2020. We use the IPSS, and then we we ask the respondents online, and then we collect 1,555 subjects, including 800 males and 700 females from 7 different cities in Indonesia, with mean age 57. And you can see here that nocturia is the second most prevalent symptoms of the lower urinary tract symptoms. The first one is frequency. And if you compare with avoiding symptoms such as incomplete emptying, intermittency, weak stream, and straining, the storage symptoms is more prevalent. And if you divide it by gender, you can see that one-time nocturia, the male and female population is similar. And then in twice per night, the male is somehow a little bit higher. And then in 3 times nocturia, we can see the dominance of the males now. And for age, we found that in nocturia is most prevalent in the age group of 51 until 70 years old. And as expected, that we found the most is 1 time per night, and then the least is 3 times per night that the patient has to get up. And then this is I think this is the really interesting data that if you have more nocturia, if you have more episodes of nocturia, then your quality of life is going to be worse, like this showed here in the data. So I'm going to share to you a guideline that's going to be launched shortly, because we compose a panel consisting of multidisciplinary specialists, including urologists and then internal medicine and also ear specialists. And we can see that factors causing nocturia are a lot. So we urologists tend to think of nocturia as the symptoms of only BPH or bladder outlet obstruction or overactive bladder. However, there are a lot of other causes, such as in the nephrology, salt and water diuresis, diabetes insipidus, and diabetes mellitus also. And also it can be a symptoms of a sleep problem, for example, obstructive sleep apnea and low dopamine level. The patients with congestive heart failure and hypertension can also exhibit symptoms like nocturia. And also diet. If people, for example, taking too much water before they sleep, or taking too much salt consumption before they go to sleep, then they can also present with nocturia symptoms. So the evaluation it's rather thorough, I think. So from history, we have to ask about the lower urinary tract symptoms itself. And then to exclude the differential diagnosis, we have to ask about the hematuria, dysuria, and cardiac problems, respiratory problems, and also problems in neurologic system. For females, we have to look at the aspect of gynecology. For example, the pelvic organ prolapse and menopause. And interview of the diet is really important, because, for example, from just a thorough interview diet, then we can exclude the diet causes of the nocturia, and also the current medication the patients are taking. This is really important because a lot of drugs can contribute to the nocturia symptoms, and also the psychological problems of the patient. A few questionnaires can be used for this condition. The most simple, I think, is the ICIQ nocturia. It only consists of 2 questions. And the other is ICIQ nocturia quality of life. And Tango, this is a rather longer questionnaires. And for physical examination, we have to examine the BMI, the blood pressure, heart and lung, abdomen. We have to look for a for bladder, and we have to evaluate also the prostate to eliminate the enlargement of the prostate and also prostate cancer. And then also in women, of course, we have to look for the pelvic organ prolapse and also vaginal atrophy, which is usually found in a menopause patient. And for blood diary, this is rather important. I will go back in the next slides for this. We're going to highlight a little bit about bladder diary. And for lab, it's usually a very simple test like renal function test, a PSA, electrolytes. This is really important, and I will explain it in the next slides why. Blood sugar, urine analysis, uroflowmetry, and post-void residual volume. This is all the office-based urologists are usually, it's very common that we do it in the office base. So bladder diary, we all know about this, but I know that some of us are reluctant to use this, but anyhow, this is a really useful tool. We can gain a lot of information from this tool. We can know which type of drinks the patients are taking, how much are they drinking per day, and then about the voiding, we can know the voided volume, we can know the frequency, the 24-hour production of the urine, and also the nocturnal voided volume, the nocturnal urine volume. That's how we're going to differentiate the patients with nocturnal polyuria or not. And then we can note if the patient has urgency, and then we can also note if the patient has incontinence. So there are a lot of formulas that we can use to determine if the patient with nocturia actually has the nocturnal polyuria. So the most common formula we use is the nocturnal polyuria index, which is the nocturnal urine volume divided by 24-hour urine production. So there are a lot of standards, but the most frequent, the most common that we use is more than 33%. It's usually in patients older than 65 years old, and in younger individuals, we use more than 20%, and middle age is around 50 to 60, is around 20 to 30%. And there are also Nocturia index, which is nocturnal urine volume divided by maximal voided volume. If more than 1, then we can determine the patient has nocturia, and if it's more than 1.5, we can determine that the patient has nocturnal polyuria. So this is an example of an actual patient, both complaining of nocturia. I have to note here that if you ask a patient to fill out a bladder diary, you have to ask the patient to also note when are they going to sleep, at what time, and what time they are waking up. So the nocturnal urine volume is excluding the volume that the patient avoid before they go to sleep, but including the urine volume when they wake up the first time. So this is in a red box is the nocturnal urine volume, and this is also the nocturnal urine volume. So both of these patients complain of nocturia. They have to get up 3 to 4 times a night. But as you can see here, the nocturnal urine volume of this patient is actually 700. So if you calculate, the NPI is 35%. And this patient, if you calculate, the NPI is 20%. So it is clear that probably the patient here is suffering from nocturnal polyuria. And this is an interesting survey done in the urologists in Indonesia, how they manage nocturia. And then we found that only about half of the urologists, the subjects were 124, and only half of them used the bladder diary, Maybe this is understandable because bladder diary are time consuming, and it takes a lot of time to explain to the patient, and it takes a lot of time to interpret the result when the patient comes. And that even though you're explaining correctly, then the patient still comes with a wrong feeling of the bladder diary. So it's understandable that it is less used by us, although it is very, very useful and we can gain a lot of information. So this is a very interesting paper published in 2019 from Korea. This is comparing two groups. In group A, the doctor explains to the patients why they have to write the bladder diary. And then the nurse explains how to write the bladder diary. And in group B, only the nurse explains how to write the bladder diary. And the results showed that the response rate was higher in group A than in group B. So it seems that if we take the time to just explain to the patient why the bladder diary is necessary for their diagnosis and for their treatment, I think the response rate of the patient is going to be higher. And this is another examination that is I think all urologists are doing. This is uroflowmetry and postvoid residual urine. This can also exclude other problems of lower urinary tract symptoms like small voided volume and then poor flow, and then we can measure the postvoid residual urine, because sometimes when people cannot void properly and they have like a lot of residual urine, and then they exhibit with the symptoms of nocturia because their bladder are always full, so they keep going to the bathroom but they cannot empty their bladder properly. Looking at the bladder ultrasound, then we can see also, or we can exclude the other differential diagnosis such as tumor of the bladder and also the stone of the bladder. For treatment, we recommend for the first line is always the lifestyle and behavioral intervention. And then the second line, if it doesn't work, then we can offer the pharmacological treatment. What can we offer, or what can we explain to the patient regarding the lifestyle and behavioral intervention? The patient can minimize the fluid intake. This is important at least 2 hours before sleep. And then if it's okay with the patient, if its comorbidities allow, then we can offer the patient to have a fluid consumption of less than 2 liters per day. Don't forget to empty the bladder before sleep. And because nocturia is associated a lot with a risk of falls and fractures, it's better to suggest to the patient if the patient has a barrier-free access to toilet, because you can imagine if the patient is getting up from sleep, he's not really alert yet, and then has to go to the toilet in a rush, then it's going to increase the risk of falls. And then exercise and increase fitness level to decrease salt intake, and then lose some weight. And then if the patient has peripheral edema, we can offer the patient to elevate the legs above the heart level a few hours before sleep. And if the patient, for example, taking diuretics at night, we can propose the patient to take the diuretics on the mid-afternoon. So for the pharmacological treatment, there's one that we recommend, which is desmopressin. It's a synthetic analog of vasopressin. Vasopressin itself is a hormone secreted from the pituitary gland. It acts on the kidney to promote water reabsorption. So the main cause for nocturnal polyuria or nocturia is insufficient FEP in the kidneys or resistance of the renal FEP. So giving the desmopressin, we're hoping that it will increase water reabsorption, and then as the result is going to decrease urine output and in the end nocturia. there are 3 receptors for vasopressin, namely FE1A, FE1B, and FE2. The receptor FE2 is, I think, is the most important in this case because it is found in kidney, and then the FE1A is found in the vascular smooth muscles, and FE1B in the anterior pituitary. So desmopressin has no effect on the FE1 receptors, but it has a greater effect on the FE2 receptors. So this is actually an advantage because it avoids undesirable vasopressor and ureterodynamic effects. So this drug is also a rapid onset of action, and once again it increases reabsorption of the water, hence it will decrease the urine production. One of the side effects that we are concerned about this drug, about the desmopressin, is the hyponatremia. This is understandable because if the water is reabsorbed to the body, and then the body is going to, the vessel is going to be diluted, so it's going to present itself as a hyponatremia, and especially a concern in the female patients. So this is an interesting study, why the female patients is more at risk of developing hyponatremia in desmopressin. This is a study done in rats, in female. We can see the blue one is female and the male is rat. Then we can see that the expression of the FE2 receptor, both at the mRNA and protein levels, are higher in females compared to the males. So maybe this situation is similar in human, where females tend to have a more expression of FE2 receptors. That's why putting us at risk, putting the females at risk for the side effects of the desmopressin more. And looking at the mechanism of action of these drugs, then we recommend a few contraindications, such as frail elderly, and then a severe renal disturbance. The cutoff is eGFR of lower than 50. If the sodium level is lower than 130, we do not recommend to give the desmopressin right away. And if the patients are taking pharmacological treatment that strongly could cause hyponatremia, like thiazide, diuretics, lithium carbamazepine, and then severe leg edema, congestive heart failure, class 2 or higher, uncontrolled diabetes mellitus or hypertension, and psychogenic polydipsia. So in this situation, please treat condition first if possible and wait with desmopressin treatment. And this is also important. Once you start the desmopressin, you have to follow up the patient, especially for electrolytes, for sodium check. So this has to be done within 7 days of treatment, because the incidence of hyponatremia usually occur in the first week of treatment. So that's why we are recommending that in 7 days, you have to check the electrolytes of the patient, the sodium of the patient. If the patient has a low sodium level, lower than 130, we recommend the therapy, the desmopressin, to be stopped. And if the patient has 130 until 135 with symptoms of hyponatremia, we also recommend the treatment to be stopped. What are the symptoms of hyponatremia? It's nausea, vomiting, headache, confusion, somnolence, and so on. If the patient has a normal sodium after 7 days of treatment, then we can pursue the treatment. And after 1 month, we can check again the sodium level, just to be sure that there is no hyponatremia without any symptoms. And a lot of questions regarding how long the desmopressin can be given to the patient. So I found two really interesting paper, one in the left is in women, and one on the right is for men. This is all a systematic review following a lot of randomized control trials. And from this paper, they said that desmopressin is efficacious and also safe, and they follow up until 12 months without any increase in major adverse events. So from this paper, we can conclude, although the females are more at risk, we can conclude that it is safe for females and also for males. And in conclusion, we can conclude that nocturia is a prevalent condition, and it certainly affects quality of life. You can imagine if you have to wake up 2 to 3 times per night or maybe more, then you're going to feel awful the next day, and then it's going to affect your work and so on. And there are several factors contributing to nocturia. So nocturia is not only caused by BPH or overactive bladder, it's also caused by another diseases, another condition. So we have to be very careful to make a diagnosis. So it is usually a multidisciplinary approach, and I especially highlight on the use of bladder diary here. And the management also includes a multidisciplinary approach, starting with the first line, which is lifestyle and behavioral intervention. And then the second line is pharmacological treatment, and the current recommendation is giving desmopressin for the nocturia with nocturnal polyuria. So thank you for your attention. Let's conclude my talk.
Thank you, Dr. Harrina, for the nice presentation. There is a question. Maybe this first question, it's not related to the nocturia. It's still about the for patient with a pain bladder syndrome. What is your opinion about intravesical bladder cocktail installation to replace hyaluronic acid installation in interstitial cystitis patient? Because as we know, many of our patients in Indonesia don't have enough money to buy the hyaluronic acid. Thank you.
I'm sorry, I didn't catch the first sentence, Dr. Anugrah.
Yeah. What is your opinion about intravesical bladder cocktails such as lidocaine and heparin and or some kind like that? Yeah, because the hyaluronic acid is pretty expensive, and not all of our patient has enough money for that. Thank you.
Yeah, you're right that the installation of hyaluronic acid is unfortunately still expensive, and it's not yet covered by the National Insurance of Indonesia. And so with lidocaine and the heparin, the level of evidence of several guidelines, it's not strong enough. So for the recommendation, for strong recommendation, like Professor Dirk the Reader has shown you, that even the hyaluronic acid is recommended weak in the several guidelines. So in only installation of PPS is recommended strong. So we can try with the lidocaine or the heparin. However, the level of evidence, I think it's not sufficient enough to recommend a strong recommendation for those treatments.
Thank you, Dr. Harrina. Another question. This one is regarding to the nocturia. Why do we need to examine the sign of vaginal atrophy? And is there any place for hormonal therapy for treating in nocturia patient? Thank you.
Yeah, this is a very good question, because we have one of the factors that causing the menopause is hormonal aspect. And the sex hormones like estrogen and then androgen is actually has contributing factors to our diuresis. So if we have a menopause patients, then we have to look for the vaginal atrophy that might be contributing to the nocturia symptoms. And the guideline says, the ICI's guideline says that if you have menopause patients without any menopausal symptoms, but the patient has nocturia, then you can start with the desmopressin treatment. But if the patient does not complain of nocturia and no other menopausal symptoms, then you don't have to give anything to the patient. So that's my answer, because hormones affecting our external genitalia and also urinary tract is also contributing to the diuretic process. So if it's declining, then the diuretic process is going to be disturbed also. So that's why the nocturia is more common in aging population, including in the female section of the population.
Thank you, Dr. Harrina. And another question, we noted that bladder diary is one of the most important key in diagnosing nocturia and nocturnal polyuria. And do you have any tips and tricks how to educate patients to fill in the bladder diary? Because some patients like don't feel it right. I mean, like sometimes they record their micturition, sometimes not. Thank you.
Yeah, I mentioned earlier in my slides that this is also a challenge for me, and I'm sure that it's all a challenge for the urologists. So what we can do is try to make some time to explain to the patient importance why the patient has to fill out the bladder diary properly. If the patient has a cognitive function disorder, for example, if the patient is like a frail elderly, we can talk to the caregiver or the family and explain properly how to do the or how to fill the bladder diary. In my setting, in my clinical setting, we usually involve the nursing staff to do this as well. We have trained them to explain properly how to make the patient understand that they don't only have to feel the frequency of the voiding, but they also have to measure it, because it's important that we know the capacity, the milliliters of the voided volume they are voiding. So, and then another thing that is also a setback is sometimes people or patients comes back to the practice with a bladder diary, and then the physician are looking at all those numbers and they have to add by themselves, and it's going to take an even more time, and then they have to interpret it. So we in the Indonesian Continence Society has tried to make the electronic bladder diary in Indonesian language, so it's going to launch shortly. So the people maybe can fill out, and then it will automatically be calculated. And then when they come to the doctors, and the doctors only see the results, the final results, so it won't take too much time for us. But for the patient itself, I think there's no other effort but to explain really what the use of the bladder diary and also how to fill it properly. So if not possible to the patient, then to the caregiver or the family that's helping the patient day to day.
Thank you, Doc. Another question. How long can we give the lifestyle intervention prior to the start of the pharmacotherapy to treat the nocturia? Thank you.
Yeah, usually we give the lifestyle intervention for 2 weeks, and then we observe the patient, and then we ask the patient to fill out the bladder diary again. I have one patient who is given the lifestyle intervention because he drinks too much at night. And I only gave the explanation that you have to drink less, especially 1 to 2 hours before sleep. And then 2 weeks later, he came back with the bladder diary, and the nocturia was getting so much better. So this is important that you explain this condition might be contributed by the lifestyle and the behavioral. And some of the patients actually succeed in just receiving the first-line treatment, and you don't have to use the pharmacological treatment. So as long as you explain what is actually causing the symptoms and what are their behavioral that will contribute to the symptoms, and then they actually doing the therapy, the lifestyle therapy very diligently, then I'm optimistic that it will get better, the symptoms will get better. So I will recommend 2 weeks of observation. If 2 weeks and the patient is doing everything right and there's no improvement of the symptoms, then we can go on to the pharmacological treatment.
Thank you, Dr. Harrina. Because of the time limitation, we shall proceed to the third presentation. The third presentation is from Professor Oh. Professor Oh is currently Professor of Urology at Seoul National University, specialized in Neuro Urology and reconstructive surgery. Professor Oh pursued a clinical fellowship at Asan Medical Center in Seoul and research fellowship at Ann Arbor, USA. Over the past 25 years, Professor Oh author and co-author of more than 200 peer-reviewed papers and contributed to more than 15 book chapters. Because Professor Oh still have another presentation, as well, we will proceed with the pre-recorded video, and afterward, I hope that Professor Oh can join us for the discussion. Thank you. Dr. Rahardjo.
Okay, thank you, Dr. Anugrah, for the opportunity. Now I would like to try to play video from Professor Oh.
Good afternoon, ladies and gentlemen. It is my great honor to be invited to this valuable Indonesian Urological Association meeting. Due to the corona infection sweeping the world, I could not go to Jakarta to give lectures. I'm sorry for this, but even in this situation, I'm very happy to be able to share my experience and knowledge with you through this online talk. Thank you for all the members of society, including Professor Harrina Rahardjo, for providing me with this wonderful opportunity. What I'm going to talk about today is the laser surgery for BPH. My lecture is divided into 4 parts: overview of the laser application, overview of the whole lab, clinical result of the whole lab, and lastly, the anatomical endoscopic enucleation of the prostate. As you are all aware, BPH is a benign condition in which prostate adenoma grows larger and blocks the bladder outlets, resulting in impaired urine flow and secondary bladder function. The surgical treatment would be to remove this enlarged prostate. The overall trend of patients in the treatment of BPH has changed significantly compared to the past. In recent years, life expectancy has increased and the patients are getting older. There are also more and more comorbid diseases. This is also true that the drug therapy becomes more prevalent. There are more patients with larger prostates. This means that prostate is getting bigger and bigger, while the risk factor for the patients are getting bigger and bigger. In this situation, there is a growing need for the development of more effective and safe surgical treatment. To date, the lasers have been available as treatment for BPH are as follows. These are Nd:YAG laser, KTP lasers, holmium laser, thulium laser, and the diode laser. Several types of surgical methods using each laser have been developed. The part marked in red is the enucleation method. First, let's look at the physical properties of each laser. This is very helpful in understanding the clinical result of each laser. The NDR laser is the first laser developed with an absorption depth of 1 centimeter and a continuous wave. The main mechanism of action is coagulation. The KTP laser is derived from the NDR laser. Each wavelength is half of the NDR laser and the frequency has doubled. Lithium borate laser is directed from the KTP lasers and have the same wavelength as the KTP. These two lasers have 0.8 millimeter. And each of the penetration depth of the holmium laser and thulium laser is very shallow, 0.4 millimeter. It is mainly absorbed by water. Restricted treatment. The absorption depth depending on the wavelengths. Let's take a brief look at the history of the laser application to the prostate. Lasers were first theoretically established in 1917 by Albert Einstein, and the first laser was born in the early 1960s. Each application to the prostate started with NDR laser in early 19th in resident training. Mainly the procedures such as BLAP and the ILC was performed. Then, after the mid-1990s, the holmium lasers were developed, followed by the KTP lasers started to appear in clinical practice. Thulium lasers began to be used in early 2000, and then diode lasers and high-power types of KTP lasers were launched. Let's take a close look at each lasers. When evaluating clinical results, it's common to compare them with TURP, which is recognized as a standard treatment. As I mentioned earlier, the NDR laser has a very deep penetration depth. Since the absorption coefficient is very low, most of the energy is converted into heat, so the possibility of thermal injury is very high. In other words, deep coagulation necrosis occurs in the tissue. This is also the surgical principle that the NDR laser destroys the tissue. Therefore, it takes about 3 months to recover from this thermal injury. Surgery can be divided into VLAP, which coagulates tissue on the surface, and the ILC, which destroys the tissue by putting fibers into the prostate. This NDR laser-induced tissue edema caused by thermal damage often makes the urethral swelling after surgery, causing urinary retention requiring catheterization, often for long period, about 3 months, in up to 30% of the cases. Unfortunately, due to these complications, NDR lasers are no longer being used in the clinical practice. In addition, NDR laser surgical outcome was worse than the TURP in 10-year long-term follow-up randomized controlled trial. Additionally, the treated patient complained of severe irritative low nitric symptoms. Another disadvantage is the inability to obtain specimen for histopathology. Next is the KTP laser. Lithium borate or LBO laser was derived and developed to improve the performance of the KTP laser. The disadvantage of the LBO laser compared to KTP laser is that the hemostatic ability is somewhat inferior. These days, KTP and LBO lasers are collectively referred to KTP. As mentioned earlier, the KTP laser has a very shallow penetration depth. Also, because the KTP is absorbed by the red blood cells, it is an excellent ability to vaporize. Commercially, 60, 120, and 180 watts are available. Let's look at the clinical result of two relatively recent type of high-power KTP. Compared to the traditional TURP, 120 watts has several advantages such as less bleeding and shorter hospital stay. However, the limitation was that you cannot find any evidence that it was better than the TURP in 1-year follow-up result. In addition, other studies have reported that the reoperation rate was significantly higher. However, it is still the advantages of less bleeding, so it can be a safe treatment for selected patients such as high-risk patients. It is about 180 watts of XPS laser. According to the representative study known as the 12-month follow-up Goliath study, It showed comparable performance to the TURP. However, although not statistically significant, the reoperation rate was also slightly higher at 120 watts. Let's take a look at the meta-analysis result that comprehensively analyzed the result of the various studies, comparing the clinical result of the KTP laser with TURP. The KTP laser showed similar effects of TURP in IPSS, Qmax, PVR, and the complications. In terms of the transfusion rate, catheter duration, and the length of stay, KTP laser performed better. However, as mentioned earlier, it can be summarized as showing higher reoperation rate in the KTP laser in long term. Next is the thulium laser. The thulium laser shows a wavelength similar to that of the holmium laser and has been introduced with various surgical techniques. Most recently, the enucleation method has also been applied. Next, diode laser. Diode laser is not a single laser, but several lasers that operate based on the semiconductor. There are several wavelengths used for the prostate, but 980 nanometer is the most used among them. The depth of penetration depends on the wavelengths. Most of the power settings are 80 to 200 watts. It was developed much earlier and it is already known, but recently it has been highlighted once again. Like holmium, some applications has been reported for enucleation. Let's take a look at the holmium laser, best known as the enucleation method. Although very few, open prostatectomy is still practiced until recently. The surgical principle used in this open prostatectomy is the finger enucleation technique. Endoscopic implementation of this surgical technique is called endoscopic enucleation. As you can see in this figure, in the case of TURP, the urethral lumen is cut out little by little. On the other hand, in the cases of HOLLAP, the adenoma itself can be completely removed by separating it between the prostate capsule and the adenoma. This is also true for the KTP laser. Holmium laser started to be used as an auxiliary method of NDR laser treatment. Then the holmium laser was converted to the resection method. After methylation came out, it was converted to enucleation and the HOLLAP surgical method was established. When resecting the prostate lobe, the entire tissue cannot be removed easily. In order to cut and remove the prostate adenoma, the methylate was developed. HOLLAP surgery was established with the development of the methylate, and the technological breakthrough of the surgery has since developed. HOLLAP basically applies holmium energy to the tissue, while the adenoma tissue is separated by the pushing, pressing, and lifting the prostate adenoma using the tip of the endoscope. In other words, HOLLAP is a surgical method that combines laser energy and the surgeon's hand motion. It is the same as when the adenoma is separated with a finger when performing open prostatectomy. HOLLAP is an endoscopic version of the open prostatectomy. Because HOLLAP removes the entire adenoma, enucleation to separate adenoma can be achieved much more efficiently as prostate size increases. Therefore, you can increase the enucleation efficacy relatively independent of the size of the adenoma. The picture is the prostate urethra before and after surgery in a patient with a total prostate volume of 76 grams. As you can see, the prostate fossa has the adenoma removed and the bladder neck is very wide open. Since HOLLAP removes all adenoma, the surgical effect is maximized and it can be said to be long-lasting. The result comparing HOLLAP with open prostatectomy at a BPH larger than 100 grams is very impressive. There are no difference between the two groups in preoperative status. At follow-up up to 5 years, the reoperation rate was 5% in HOLLAP and about 6% in open prostatectomy, indicating the HOLLAP was superior. The advantage of the HOLLAP is that there is no TURP syndrome seen in monopolar TURP. Because it has the same surgical principle as open prostatectomy, it is good for very large prostate. Since it is a holmium laser, it can be also remove bladder stones at the same time. The bleeding is less and the hospital stay is short. It is known that even patients who use anticoagulants such as aspirin can perform surgery without stopping it. I will briefly introduce the whole lap surgical technique. When the original whole lap surgery was developed, the 3-lobe technique was used to remove it into 3 pieces, such as the median lobe and both lateral lobes. However, there has been remarkable advances in surgical technology since. Eng-block method has been developed and removed adenoma into lumps, and it can be said that surgery has become more diverse. However, there is a lot of controversy as to whether the Eng-block method has any advantages over the original 3-lobe technique. The method of whole lap surgery technique that I perform has also changed a lot. Basically, I'm using the 3-lobe technique. I'm setting the laser setting at 2 joules with 40 Hz or 80 watts. Surgery is being performed with irrigation fluid at a height of 60 centimeters. First, the median lobe is separated, followed by the left lobe, and then the right lobe is removed. Most recently, I have improved my surgical technique a little bit so that I'm performing so-called early embodied V-shaped apical mucosal incision, which is mainly aimed at minimizing sphincter damage. For more information on my surgery, please refer to the video on YouTube. Next, let's take a look at the clinical result of the whole lap surgery. I will first tell you about the meta-analysis result that combines the result of various papers, and then I will talk about my personal surgical experience. The result of the 2015 on European Urology are very encouraging. Compared to the TURP, the whole lap performed better in terms of catheter duration, hospital stay, Qmax, possibly residual, IPSS, and the reoperation rate. However, the operation time took longer in whole lap than in TURP. In summary, it can be said that the whole lap is better surgical efficacy, and overall, its safety is better than that of the TURP. The clinical results of the whole lap compared to open prostatectomy are also very impressive. Compared to open prostatectomy, safety indicators such as catheter duration, length of the hospital stay, and the perioperative transfusion has been improved. Both were similar in terms of the efficacy and complications. Of course, whole lap took a little bit longer operation time. Next, I will introduce 2 of my clinical studies. I have computerized data on about 2,500 cases of whole lap at Seoul National University Hospital over the past 12 years. I'm enrolling whole lap surgical patients prospectively, so I'm running the prospective BPH database registry. The result of the first paper shows that whole lap is safe and effective even in patients with very large prostate. Patients were analyzed by dividing into 3 groups: patients under 100 gram, over 200 gram, and in between. There are 70 patients between 100 and 200 grams, and 6 patients with more than 200 grams. The total IPSS score was about 13 to 18 points before surgery. In patients with more than 200 grams, enucleation took about 76 minutes and modulation took about 47 minutes. As I mentioned earlier, enucleation efficacy was higher in larger prostate. In patients with larger prostate, there are many hard nodules within the prostate that are very resistant to modulation. In this case, the nodule must be removed by TURP, or the adenoma must be removed by small incision or cystostomy. These cases were more common among patients with larger prostate. Hospital stay was about 3.5 days for patient over 200 grams. Considering the fact that the patient was admitted 1 day before surgery, the actual hospital stay is 2.5 days after surgery. The catheter indwelling period after surgery is usually 1.7 days, but in patients over 200 grams, it was about 5 days. Even in patients with larger prostate, there were no significant complications after surgery. Urinary incontinence is shown to be more common in patients over 200 grams, but it was actually patients with preoperative urgent urinary incontinence already. One patient had urethral stricture, but this patient had a preoperative urethral stricture. In other parameters, there was no significant difference among the three groups. The degree of improvement in IPSS and Qmax after surgery. All three groups improved significantly at 6 months after surgery compared to preoperative status. Symptom score and Qmax improved significantly. In conclusion, it can be said that the whole lab is a safe and effective method even in large prostate. Next is the patient satisfaction after whole lab surgery. At 6 months after surgery, patients were asked to respond to 3 questions. There were 3 main questions: satisfaction to treatment, overall response, and willingness to undergo the surgery again. In response to satisfaction to treatment, 91% of patients were satisfied with the whole lab surgery. In overall response, 99% of patients said that the symptoms improved. 94% of patients responded they were willing to undergo surgery again, even if they decide to undergo surgery again. In conclusion, it can be said that the whole lab is a very satisfactory operation in terms of the patient perspective. The enucleation method is not limited to whole room laser. Recently, it has been widely spreading to surgical techniques using other energy sources. Therefore, all of these enucleation methods are referred to as AEP or EEP. Of course, the origin of the AEP is the whole lab method developed in 1998. Although the energy source is different, the surgical method is similarly applied to the 3-lobe technique. Several energy sources including bipolar, green light, thulium, and diode. A lot of research on surgical technique is also studied. The result of meta-analysis comparing the efficacy of these enucleation surgical methods were recently published. A total of 35 randomized controlled trials were included in this analysis. Compared to resection vaporization, which is non-enucleation method, enucleation method presented greater Qmax, less catheterization time, less length of hospital stay, less hemoglobin decrease, and less transfusion rate. However, enucleation method shows longer operation time and higher rate of bladder injury. Among the enucleation methods, the result of 4 papers comparing laser and non-laser methods were analyzed. Laser enucleation method provided greater tissue removal and smaller hemoglobin decrease than non-laser enucleation method with the same similar functional profile. Multiple laser therapies have been developed as less invasive options compared to TURP for the treatment of BPH. ND-YAG laser has been abandoned for the lack of long-term efficacy and variable clinical efficacy. Currently, most well-established laser therapies are whole lab and KTP laser ablation. Both has good safety profile and efficacy. Whole lab is time-tested and each efficacy is long-lasting. Different energy sources have been used for enucleation. The surgical techniques are largely similar to that of the whole lab. 2-lab and diode laser enucleation are promising new modalities, but need more randomized controlled trials and long-term follow-up studies. Thank you for your attention.
Thank you, Dr. Harjo, for sharing the presentation. I hope that Professor Oh is already with us. But first, before I go with Professor Oh, I would like to ask the question to Dr. Harrina. There are another 2 questions. The first one, is there any difference regarding the treatment for nocturia and nocturnal polyuria? Thank you.
Yes, so the pharmacological treatment, the desmopressin, is recommended for nocturia, and it works best in nocturia with that is caused by nocturnal polyuria. But nocturnal polyuria contributing to nocturia is around 70 to 80%. So it is the number is high. So it is important for you to take the data from bladder diary and establish whether this patient has nocturnal polyuria or not, because these types of patients will respond the best with desmopressin. rather than non-nocturnal polyuria patients.
Thank you, Doc. And the second question, is there any role of pelvic floor exercise in nocturia?
Yes, so if the nocturia is caused by the reduced functional bladder capacity, such as that we see a lot of in OAB patients with nocturia as well, then the pelvic floor training is actually a kind of patient. But we have to be careful to exclude any obstruction in this patient, because it's not rare that the people with reduced bladder capacity is with concomitant obstruction. So with obstruction, we have to be careful to prescribe pelvic floor training, because it's going to contribute to the voiding symptoms more.
Thank you, Dr. Harrina. First, I would like to greet Professor Oh. Thank you for joining with us today, Prof, despite your very tight schedule.
I'm sorry that I was away from the webinar for a while due to an overlapping of my schedule. Sorry for that. And it is very nice to meet you via the webinar, Dr. Harrina.
Hello, Professor Oh. Thank you for joining us. Thank you very much.
Thank you.
Professor Oh, we already have two questions for you. The first question, which laser can give the fastest learning curve in your opinion?
The first question is learning curve of a whole lab?
Of the overall laser, which one is will give the fastest learning curve?
Yes, actually, this is a very good question, because the enucleation method, whatever the laser sources are, I think it's a very different surgical principle with the traditional PVP or transversal resection. But I think it needs few cases for becoming familiar with the procedure. But in my personal case, around 13 cases were needed for me to be comfortable with the surgery. But in general, in the literatures, usually it depends on, it's different from the researchers and the surgeons, but usually 10, 20 or 30 cases are needed for the overcoming the learning curve. So practically, I would suggest that the surgery cases should be in line, regular terms like this week 2 patients, next week 2 patients, and 2 weeks later 2 patients. So the practice should be continuous, and also the surgeons have to focus on more focus on his own surgical techniques. I recommend the record your surgery videos, and after surgery play your surgery again and review very critically, and try to think what should be improved further. And also there are many expert surgeons video is available, so I think this should be helpful. And in fact, there should be some more effective ways of overcoming the learning curve, such as the training modules. Either it's either virtual or the actual simulators, but there should be some the tools. And also the proctorship is also very important. If you start to perform the whole lab, and there should be some expert to supervise you. And I think there are many many ways to for you to overcome the learning curve.
Thank you, Prof. And would you prefer suggest to start with a smaller prostate, or any volume will do?
Yeah, that's also a very important question. For very extremely large prostates, it's very difficult to do surgery because there are a lot of arterial bleeders. So the bleeding might hinder or prohibit the actual surgery. It is not good for the beginners. But on the other hand, very small prostate like 30 or 40 grams, I think it's also not suitable for beginners because the capsular plane is not well developed. So I think that's not also good for the beginners. So I think the optimum size of the BPH for before overcoming the learning curve should be around 50 or 60 grams. I think that will be the most suitable for cases for whole lap surgery for beginners.
Thank you, Prof. Another question regarding the post-enucleation structure post whole lap in whole lap procedure, how it's compare the structure incidence in whole lap and the TURP?
Is it about the urethral stricture?
Urethral stricture, I mean, yes.
Okay.
Sorry, yeah.
So in my case, I think around less than 1% of urethral stricture and also the bladder neck contracture cases. But I usually I use 26 French the sheaths of endoscope, resectoscope for whole lap surgery. But I found that the urethral stricture and the bladder neck contracture was not that common in my 2000 cases. But I think there's no difference in terms of the development of urethral stricture in TURP or whole lap.
And what about the retrograde ejaculation after whole lap procedure?
Yeah, I also did some clinical studies in terms of the retrograde ejaculation, but I found that around, I can't actually remember the exact figure, but around 70% of the patient experience retrograde ejaculation, not 100%. But pre-operatively, I usually tell the patient, all the patient, before surgery that retrograde ejaculation will happen, and we can't actually can't prevent any retrograde ejaculation. And if the patient is very concerned about the ejaculatory problem, and then I usually do not do surgery because to some patients it is a great concern. Okay.
Thank you, Prof. And maybe this is one of the last questions. Do you have any tips maybe to safely conduct a morse-laser procedure after the whole lap excision, something like?
So the tip for
the morse-laser, yeah. I mean, yeah, to prevent the bladder rupture during morse-lating.
Yeah. Actually, I experienced 2 cases of bladder injury due to during the morcellation of the adenoma. all of these cases will happen in early learning curve period. And one of the most important tip that I can offer to the beginners is always makes the bladder distended all the time. So I usually have my assistant just beside the patient and palpate the patient abdomen, whether bladder is fully distended. If the bladder is not fully distended, I usually stop and wait the procedure, and again, once I confirm the bladder is distended. In some patients with the obese habitus, sometimes it's very difficult to palpate the bladder distension, but I usually try to try my best to confirm the bladder distension is fully achieved. And so the irrigation fluid input and outlet should be checked very carefully, because if the irrigated fluid is it's empty, and the bladder will be collapsed. But if the outlet is open, the bladder usually go collapsed again. So that will make the very difficult and dangerous situation. So you need to do every effort to make the bladder fully distended all the time during mosylation. And also to make the vision very clear before mosylation, the careful hemostasis is also very important, because otherwise the vision is not good, and then you cannot recognize the bladder is very near to the tip of the mosulator. It's also very difficult and dangerous situation. So otherwise, at the learning curve period, I didn't experience any bladder injury during the mosylation procedures.
Thank you, Professor Oh. I think that is the last question, and we almost 2 hours in this webinar, very interactive and very fruitful. Maybe before we close our meeting, may I ask the participants to open their video, so maybe we can take documentation from this webinar. Thank you. It's very nice to meet all of the colleagues here, even with online. And perhaps Dr. Harrjo can take the picture, the screenshots.
Okay, Doc.
Done?
Yes, thank you, Doc.
Thank you. Thank you for the organizing committee. Thank you for the distinguished speakers. Thank you for the participants for joining our webinar today. And I hope to see you again in another webinar. And I wish you a good day today.
Thank you, Dr. Anugrah. Thank you, Professor Oh.
Thank you, Professor Oh.
Thank you.
Thank you.